Well. Welcome back, everyone. So this one, there's something philosophical that I keep trying to make clear. I'm not sure if people are getting it, but it's to me very important. But first, I want to go. I think I got a doctor and sort of a. I didn't mean to do this. I mean no disrespect. I cast no shade. No. I'm not trying to be mean to Dr. Michael Chapman. I suppose is the best way to put it. I'm not trying to be mean, but so I posted these tweets, and so I meant to put this card in actually, and to save on editing, let me see if I can. My goodness. Let me see if I can do it this way. Oh, here we go. Yeah. So I'm just gonna do like this and make it simple. So this is what I meant to put this in there, and I forgot to do it. I did put it up there, but not in the thread. But it talks about serotonin syndrome. Serotonin, chemical and body produced naturally. It is needed for the nerve cells and brain to function, but too much serotonin causes signs and symptoms that can range from mild, shivering and diarrhea, to severe muscle rigidity, fever, and seizures. Serotonin syndrome can cause death if not treated. And so, just thought I'd put that out there. But then I had this to say. I've been looking into serotonin syndrome with all the tricyclic and SSRI medications they are prescribing to chronic pain patients. It's very scary. And this article about fatigue and not treating pain from the Cano Institute. Dr. Michael Chapman responded by saying, saw one case in 37 years treating chronic pain patients. She was only mildly sick. That it's common is just more information. Sigh. Well, the problem is, that being said, is it misinformation to suggest that tramadol is, what I responded with first is, I never said it was common. It's a concern, but not common. No, I never said that. I never said it was common. But that being said, is it misinformation to suggest that tramadol is extremely dangerous? That's in quotation marks by an article that I read, on the sole basis that it could cause serotonin syndrome. Seems to be serotonin syndrome is rare, correct? Enlighten me. The article I read said tramadol is dangerous. Tramadol causes serotonin syndrome. So, have I heard back from that on is serotonin syndrome with tramadol something to worry about? Because we have the experts saying that no, serotonin syndrome is very, very rare. But there was an article that I read from PubMed or NIH.gov that said that I think there was a few universities too that also said this, that serotonin is not serotonin, but tramadol is very, very, very dangerous because it can cause serotonin syndrome. Oddly, a lot of the times it says the headline would, or the article title would say in it something about how tramadol can cause serotonin syndrome by itself, but then when you read the actual study or article, whatever it is that you want to call it, I don't know what it. I mean, it reads like an article, but it's published by a university or NIH.gov or PubMed. But it would say in it that it's really only dangerous in creating serotonin syndrome if an SSRI is used in conjunction with it. And so really, the question is it dangerous? Does it cause serotonin syndrome? Because he was sitting there saying, well, serotonin syndrome is rare. Well, okay, so then the major, oh no, tramadol bad. If serotonin syndrome is rare, then that kind of takes away the argument that tramadol is bad. I don't know if I haven't heard back because it pretty much kind of puts the person on the spot of defending the use of tramadol. Because if the likelihood of developing serotonin syndrome is not very high, very rare, unlikely, then that would mean that the argument of not using tramadol, because it's dangerous because it could cause serotonin syndrome, is not a very good one, because it's extremely rare and extremely rare that it's even fatal. That's just one thing. I haven't heard back. I'm not saying that I haven't heard back because it's an I gotcha. I'm not saying, maybe he just hasn't gotten to it. I don't know. I'm going to give the benefit of the doubt. I don't like to make assumptions, but I do find it interesting. I haven't heard back. So hopefully we will get some more information on that, because I would like to know. Let's get our facts straight. It'd be good to do, right? So, moving on, there is another thing where life is art. Before I get in that, the link to the article that was in the thread with Dr. Michael Chapman that talks about fatigue and how it's hard to get sleep as a chronic pain patient and why. I will leave the link to that article in the description so that you can peruse that. I've already read it. But if you want to educate yourself, which I would highly encourage you to do, go and read the article. Go and read it. So then, the main thing that I wanted to get into is what life is art went over, and this is very, very interesting. It's about the FDA looking for the genetic marker that would suggest a genetic trait, the genetic marker that suggests that somebody has the potential or could possibly develop substance use disorder or opiate use disorder, more specifically in chronic pain patients' case. Now, they do say in there that one of the issues that the FDA has with this is that, well, just because they find the genetic marker doesn't mean that the person will develop substance use disorder or opiate use disorder, even if they have the genetic marker for it and are exposed to the substance. Doesn't necessarily mean that that'll happen. And likewise, just because the person doesn't have the genetic marker, they can't prove substantially that means that they won't develop substance use disorder or opiate use disorder. They said, it's tricky. That almost suggests to me that there really isn't a genetic marker for this stuff. Maybe there is, maybe there isn't. But she's all on board with this, and I can see why. I'm not against the idea. I actually kind of like the idea myself. It's a good idea. But I think those two things that I just mentioned, when you read through the article, they mention this. Again, I will have the link to that article, to this FDA article, in the description. Highly recommend you go and read that for yourself. I've already read it, but it discusses this in further detail. And I'm not against it, and if we do take the genetic test and all these people who have been on opiate pain management therapy for many, many, many years test negative on having a genetic trait that would suggest that of having OUD, so they don't have it. They're not getting OUD. They've been on the medication for 20 years, and then they were tapered off because of the 2016 CDC guidelines, and now they're even worse. Then it straight up proves the original CDC 2016 CDC opiate prescribing guidelines, well, wrong. That no, there was no need, no reason to do this at all. To pull all these pain meds away from all these chronic pain patients, leaving them completely abandoned by healthcare in many situations. I included in that. I don't have anything. I have no insurance. Primary care physicians won't touch chronic pain now. They won't do it. It's pain management doctors, and they're not really going to prescribe you an opiate medication. They're going to give you pain management injections like trigger points, nerve blocks, epidurals. Epidurals are, all of those are dangerous. And I'm going to get into that. But here's the sort of thread from that. Do you all realize this right here will destroy the idea that long-term use of opioids leads to addiction? Let's go. All right, so here's the thing that my whole philosophy on this sort of thing. I think that this is, and I think that there's a constitutional amendment that protects this. Sort of it's a human right violation in violating a patient's right to bodily autonomy. At the end of the day, Michael Chapman can regurgitate all of these statistics and data at me, like the morbidity rate of opiate use, the side effects, the negative side effects, or the risks as opposed to the benefits, all day long. We could do this all day long. But ultimately, this is the trouble that I have, is that people sort of get into this sort of funk where the anti-opiate people only see the good in a medication just because it's not an opiate. Like it's like they're stuck in this mentality, like, oh, it's not an opiate, therefore it can't possibly be bad. Or just because it is an opiate, oh, it must obviously be bad. And I think that that's really dangerous, because the real reality is that all these medications have side effects and withdrawals and issues and complications. And here's where I'm getting at is, like, I'm not against people using gabapentinoids like Lyrica, Neurontin, gabapentin. I'm not against people using tricyclics like amitriptyline, nortriptyline, etc., etc. I'm not against people using SSRIs like Cymbalta to manage their pain, or doing pain management injections like trigger point, nerve blocks, and epidurals if that's what they want to do. Because at the bottom line here is, in the philosophy that I'm trying to, that I want to impose upon or get people to really think about, is this. Is that the big problem with taking opiate pain medications away, first of all, when you do look at the risks, it's this teeny tiny little itty bitty amount, and then the others, like the gabapentinoids, SSRIs, and tricyclics, and even steroids and NSAIDs and muscle relaxers, it's like a book of side effects. But that's not even the issue. That's not it. Even if opiates had a book of risks versus benefits, still, it boils down to this. Even if someone has opiate use disorder, I don't know that, let's say you do the DNA test and they have the genetic marker for opiate use disorder, for OUD, I still have a problem here of taking the option of opiate pain medications away from them, because at the end of the day, this is a violation of bodily autonomy. And that boils down to a human right violation. And here's why. Is the person, patient, individual, who has the condition or the disease is the one that has to live with that condition or disease. No one else does. That person is the one who has to live with it. That person, individual or patient, is the one that has to live with the drug that they choose to take and the long-term effects of using that drug. They're the ones that are going to have to deal with it at the end of the day. They're the ones that are going to have to put up with the risks and benefits. And let's say that all of these medications have some factor of morbidity to them. Most do. Then that's the patient, person, or individual is the one that's going to have to put up with the things. They're the ones that are going to have to deal with what is killing them at the end of the day. And we've taken that right away for them to choose what medication for that particular individual person or patient condition or disease that they're treating. We've taken this ability away for them to choose which medication they are willing to live with, manage their pain with, and die with. And I'm not okay with that. Like I said, even if they had OUD, even if it means that it's going to shave off portions of their life, as a chronic pain patient, that's probably already in the book. Society has come in and already dictated to these people what medication they're going to take, how they're going to live with it, and how they're going to die with it. And they have no say-so themselves. So it's like, if you're okay with taking gabapentin and you're okay with the side effects and living with them, and you're okay with how it's managing your pain and living with that in your life, and you're okay with how it affects the way that you're going to die, then that might be the right medication for you. And the thing is like, whoever said that we can't change our mind? Like, let's say somebody does want to go on an opiate pain management regimen. Why is it that they can't at some point say, well, you know what, I'm getting tired of this. I think I want to taper off and try a different medication because I don't want to do this anymore. Why is that suddenly not an option? That's totally an option. But I have a real problem with this idea of society or a government agency or a government coming in and dictating to a person what drug they're going to take to manage their pain from their condition or their disease, and how that medication, whether that medication, the risks, the withdrawals, the side effects, that kind of thing. If it seems like society saying, well, we don't care if you don't like those, you have to do it anyway because we said so. And if the patient doesn't want the end of life that particular medication is going to give them, or let's in the case of like gabapentin, grand mal seizures, and they end up dying from that, what if they're not okay with that? What if they don't want to die from a grand mal seizure? What if they would rather die from renal failure and take NSAIDs and muscle relaxers? What if they would rather die what if they'd rather die with the risk factor of having the respiratory system suppressed and falling asleep and never waking up again? What if that's more idealistic in their mind as far as risks go? But they can't make that decision anymore because society has come in and said, no, we don't want you to take this particular medication because it can suppress your respiratory system. It causes chemical dependency. It can cause a substance use disorder. And then because it can suppress your respiratory system, ultimately kill you. So you can't have that. even if the patient is totally fine with all of that, the risks and the benefits, they're fine with the OUD. They're fine with the chemical dependency as long as they can stay on it. And they're fine with if that's the way they go, they're fine with that. But they're not okay with the other medications like the NSAIDs and the muscle relaxers. They're not okay with renal failure. They're not okay with ulcers and esophageal rupture. They're not okay with those things. They're not okay with heart failure from overuse of muscle relaxers. They're not okay with that. Or we could go to that. There's a plethora of things with steroids. I'm not as familiar with those. I had a really bad reaction to steroids. I ended up in the hospital with a low heart rate, almost killed me. So I can't even take them. I don't know nothing almost about them. I know a lot about SSRIs, tricyclics, and gabapentinoids because, well, I've been seeing psychiatrists and psychologists since 1992. And there's a lot of those medications I've been on, and I don't like a single one of them. Not almost none of them. Not a single one. I've never met any of them that have been compatible with me personally, but I know a lot about them because of this. So, you know, what if they're not okay with those side effects? What if they're not okay with, developing there's a whole bunch of things you can develop from SSRIs, including high blood pressure and muscular dystrophy. I might be challenged on that, but I'm telling you, there's muscular dystrophy is long-term use is one of the causes. Serotonin syndrome, which apparently is rare, but still, there's a lot of these things. Like, so some people might be okay with that, some people are not. But essentially what's happened is like a government agency, a government or society has come in and dictated to chronic pain patients what they think is okay for us, instead of letting us decide. And you're talking about something that is very, very personal. It's how, like I said, at the end of the day, it's that patient, that individual, that person who's going to have to live with the consequences of what pain management therapy they end up stuck with for the rest of their life. They're the ones that are going to have to deal with it. And we've taken the choice away to choose a particular class of medication, which is opiates. We've taken that away from them, even if they're okay with the risks. That's a philosophical problem to me. That's a conundrum, because that is a huge human right violation to me. You're dictating how this person not only manages their pain, you're dictating how they live their life, whether they like it or not. You're dictating how they die, whether they like it or not. That doesn't sit well with me. I really think that it should be up to the patient and how they want to treat their pain, how they're going to live the rest of their life, like what medication regimen they're going to end up dealing with for the rest of their life to manage their pain. It should be up to the individual, not someone else. That someone else that doesn't want them on opiates but wants them on NSAIDs or muscle relaxers, well, that person can go on muscle relaxers and NSAIDs. But why are we projecting all these people keep projecting their experiences, their hang-ups, their ethical or moral concerns onto everyone else that doesn't share those? Their experiences onto other people that do not share those. So, like, if you know you have OUD and you want to stay away from them, that's fine. I don't have a problem with options. I don't have a problem with options at all. What I have a problem with is taking options away, which is what has happened. Now there's a ton of chronic pain patients out there that are okay with the opiate option, but they can't have it. And that's what I have a problem with. They're condemned to a life of chronic pain and suffering and dying, all while on a medication regimen that they can't stand, if any at all, at this point. And I have to ask, is that right? Is that the right thing to do? I don't think that's the right thing to do. And the CDC is really kicking this up a notch. They're starting to attack vaping, and I know people have used vaping to quit cigarettes like all over the place. It's crazy. I know I did. I didn't even intend to. I wanted to keep smoking cigarettes. I accidentally quit. I vaped for 2 days straight, and I lit a cigarette up, and I was like, oh, gross. I quit on accident, but I'm glad I did. So, and there's actually a video I saw of the CDC panel being asked, but I'm getting off track. But in this video, this think tank guy asked them, how low a percentage of teens vaping does it have to be for it not to be considered an epidemic? And their answer was 0. So this has got to stop, because we're getting to a point where we're dictating people's life choices, and I think that's dangerous. That's sketchy, scary grounds. If you put your warning labels, educate people on the dangers, educate people like, look, these are health risks, by all means do that. But can we please stop projecting on everyone else under the sun how you think that they should live? My dad had a friend who loved cigarettes and died by cigarettes with no regrets about it. And on his deathbed, the doctor asked him if there was anything he wanted to do before he died, and he said, "Can I go out for a cigarette?" And he was denied that opportunity. I don't know why. I can't explain that. I can't rationalize that. The damage that the cigarettes would do had already been done. His final wish was he was going to die. He was going to die on his deathbed. One last thing he wanted to do was just have one last cigarette, and they wouldn't even allow him to do that. Why? You wouldn't even grant a dying man his last wish. That's where this authoritarian crap leads. And I think that's scary. That's very scary. As far as I'm concerned, if you're dying, you should be able to have whatever the hell you want. I think if a dying man's wish is to do a speedball, even though that'll kill him, let him do it. They're dying. They're on their deathbed. Let them do it. Why not? If that's what makes them happy, if that's what gives them pleasure, what's the problem? What are we worried about at that point? They're dying. They have a final moment left of consciousness before it's gone. I am an atheist, so nihilist, that's where I stand on that. There is no afterlife. Eternal consciousness, that's all crap. This is all you get. So I'm really bothered by this. And it bothers me that this is something that is not being considered, is the patient's bodily autonomy and basically their right to choose on how they live the rest of their life and manage their pain and die. So, maybe opiates do have all these risks as these undesirable things for you. But for a lot of people, it's a saving grace. So, I guess the dictators win. I'm not a big fan of dictators. I hate dictators. I hate authoritarianism. I hate it. It's not cool. Yeah. So, Was there something else I was going to add? I think that was about it. I'm keeping it simple again with this recording. But so yeah, but that's the crux of it, is I at the end of the day, what it all boils down to is the individual patient or person. They're the ones that have to live with the chronic pain condition or disease. They're the ones that are going to have to live with the consequences of whatever pain management regimen that they go on. And for anyone to dictate that to them, I think that's kind of fucked up. I think that's a violation of bodily autonomy and a human right violation. And it's actually very, very sad. It's cruel, it's crooked, it's dark. And just think about how authoritarian it is. It's extremely authoritarian. Extremely. Well, with that, like, share, subscribe, comment, and